Good evening for joining us on number 13 in our series on COVID-19 vaccines, specially targeted education programs, building COVID-19 vaccine confidence by educating the educators. Thanks for joining us. So this evening, I just want to remind you that these programs are recorded, and we're hoping that we'll have a very engaging interaction with our renowned speakers. And to remind you that this program is being run in collaboration with the SickKids Learning Institute, the Black Creek Community Health Center, the Scarborough Health Network VaxFax Clinic, and the Black Physicians Association of Ontario. This evening, we are going to look at treatments and related issues, what's new and what's hot. And what I will begin with a land acknowledgement. Then I will introduce the first speaker in the person of Dr. Upton Allen. And when he's done, we'll have 15 minutes of Q&A, and that will be followed by Dr. Michelle Barton-Forbes, and we'll have her Q&A at the end of the session. So hopefully we're going to have good interaction, and make sure that you post your questions appropriately in the Q&A. Now to the land acknowledgement. We would like to begin by acknowledging the land on which SickKids operates. For thousands of years, it has been the traditional land of the Huron-Wendat and the Petun First Nations, the Seneca, and most recently, the Mississauga of the Credit Valley. Today, Toronto is home to Indigenous peoples from across Turtle Island. SickKids is committed to working toward new relationships that include First Nations, Inuit, and Métis people. And it's also grateful for the opportunity to share this land in caring for children and their families. So to begin, Dr. Upton Allen, who really needs no introduction after having led the series for the previous 12 times, is the head of infectious diseases at SickKids and a senior associate scientist at the Research Institute. Is well renowned as an infectious disease expert, having been the director of the Infectious Disease Society of America. Dr. Upton Allen was awarded the Order of Ontario for his seminal contributions in the area of infectious diseases. So what Dr. Allen is going to do this evening is to look at the vaccine component of the topic. And after he's done, Dr. Barton-Forbes will look at the treatment component. So we'll have a good combo this evening. Over to you, Dr. Allen.
So as I thank you so much, I sincerely appreciate the opportunity to be presenting along with Michelle Barton-Forbes and moderated by you, session number 13. My disclosures are shown on this slide. Research funding as shown, where this funding comes to the institution, no personal financial benefit to the individual. And then some research, some clinical program support, again, no financial benefit directly to me. The outline of what I'll present is shown here, where I'll focus on some questions, Isaac, which I thought might be the way to go. So on the issue of safety, what is new? And then what do we protect against when we use vaccines, such as the COVID vaccines? What are some of the new vaccines that are on the scene? What are the ingredients in the vaccines? And would third or fourth doses provide any additional benefit? And what about safety with respect to third doses and timing of third doses? At different points, 3 different points during the presentation, I'll focus on safety. I'll mention safety to begin with. I'll come back to safety when we talk about ingredients, and then when we talk about the third doses. So what's new with respect to safety? This is an area that we watch very carefully. literally every week to ensure that if there's anything emergent, we can identify and know how to counsel people accordingly. But as you know, the issue of vaccines in adults and children is one that relates to a trade-off between benefits and risks. In green, you can see potential benefits in preventing illness of varying severity, and then reducing disease transmission. But there are risks. In red, I think, with respect to the COVID vaccines, while there are different side effects that have occurred, ones that are foremost in our minds are pericarditis and myocarditis. There are other adverse events as well. Fortunately, these most feared ones, myocarditis and pericarditis, happen to be very mild indeed and extraordinarily rare, particularly more so among children before puberty. And just so that we're all on the same page, the pericarditis refers to inflammation of the outer lining of the heart, and the myocarditis, inflammation of the heart muscle. But beyond these and beyond other things like allergic reactions and soreness of one's, site of injection and headaches and fevers, is there anything else? And more recently, the World Health Organization has reported on a possible signal that is still being evaluated. So whether or not the COVID vaccines are associated with hearing loss and tinnitus. This is still being evaluated. There are reports that suggest no increased association with hearing loss and with tinnitus. But there are other reports that suggest that there might be an association. So at the moment, it is still being evaluated. The important thing, though, is that based on the data that we've seen so far, it's incredibly rare. And in fact, one way to look at this is to look at what WHO is looking at right now in terms of the number of cases of tinnitus or ringing in the ear and the number of hearing loss in relation to the number of doses of vaccines that have been administered so far. So some conflicting reports, it's on our radar, but in counseling individuals, I think you can safely say that this is extraordinarily rare, and when it does occur, it actually tends to be not severe. I thought, though, that we should look at the list of other types of events that are occurring in different age groups. So this is Public Health Ontario, and it shows that there's work being done to capture adverse events of interest across various age groups. And these are being documented. Cause and effect relationships sometimes are not clear, but the important thing is that the monitoring is in place to pick up these rare events if they do occur. If you look at the number of adverse events of interest being reported to Public Health Ontario, you can see in green would be the non-serious events. And the serious events you can see in this peach color, and those are very rare. But so the overwhelming majority of these events that are reported are non-serious events. Now, this particular slide is not meant for you to see the details of everything, but I just want to highlight the top 10 most frequently reported adverse events are shown here. And basically at the bottom of that top 10 is the myocarditis, pericarditis in terms of the frequency of reporting. Now, what are we protecting against when we give vaccines? And this is an area that, as I've said before, we perhaps could have done a better job of articulating more clearly in terms of our message to the public. So vaccines, generally, when we give vaccines, they target a spectrum of severity. At one end would be any infection, which might be mild. And then in the middle would be moderate and severe disease. And at the extreme would be mortality where appropriate. And I want to illustrate this by using lessons that we've learned from other vaccines, chickenpox. So when the chickenpox vaccine first came about in the 1990s, it was a one-dose vaccine that was being used in children. And what was being prevented was, severe disease, mortality, and what was demonstrated was that individuals, if they got chickenpox with one dose of the childhood regimen, might still get mild illness. And so on the left would be more moderate to severe chickenpox. On the right is mild chickenpox with one or two lesions, more than one or two, but just, very few lesions. But bottom line is that people are still getting chickenpox, but when they got it, it was incredibly mild, and they basically, for the most part, continued their lives. Of course, there's always a risk that they could transmit to others. So what happened was that when they looked at the overall effectiveness of the vaccine, they found that one dose was effective about in an average about 81% in terms of effectiveness as far as all chickenpox. For moderate to severe disease, it was more effective, 96%, and for severe disease, it was 99%, close to 100% effective. And so if you look actually at how things came about with chickenpox in 1997, when the vaccine came on board initially, only about 26% of people wanted to be vaccinated, in terms of wanting their children to be vaccinated, in contrast to measles. It took a number of years for us to get up to the 80s. So it was a hard sell initially, I think. And then it took a while to get up to the 80s. And about 2006 came the second dose being implemented because it was discovered that one wasn't enough. So it actually took close to 10 years to figure this out, unlike the situation with the current COVID vaccines. But what happened then is that once it was clear that we needed two doses, and two doses were implemented, it was essentially 100% effective in preventing severe disease, but one could potentially still get milder disease, but still effective 98%. And so what we're seeing play out with the COVID vaccine in real time is essentially what we've seen play out with the chickenpox vaccine over a period of a decade to figure this out with COVID, because there's so much COVID happening in such a short period of time, we're able to figure this out in a much shorter period of time. So what are some of the newer vaccines that have come on the scene? This is really interesting. Let me say that there are some disappointments. I'm going to be very frank, there are some disappointments, but there's some great things. So just to put things in some perspective, at the end of the day, in terms of interacting with the immune system and generating a response, it's all about the spike protein. And with the AstraZeneca vaccine. We have an adenovirus vector, which is a safe viral vector, delivering a gene that, as I'll show you on the next slide or two, leads to the production of mRNA that leads to the production of spike protein. With the Pfizer and the Moderna vaccine, a lipid nanoparticle delivers the mRNA that encodes for the production of the spike protein. The Novavax, which is a new one on the block, we are actually delivering the spike protein as a synthetic nanoparticle coated with a trimer of the spike protein, 3 different components you can see, coupled with an adjuvant that is immune boosting. But at the end of the day, it's all about the spike protein interacting with the immune system. And just to recap, the mRNA vaccines, the spike protein mRNA code is delivered, and our bodies, our immune systems respond by producing spike protein, or immune systems respond to that. The mRNA is broken down, disappears within 24 to 72 hours, doesn't get anywhere the nucleus is, where the nucleus is, that's where DNA is. And the example that I've used is, imagine all of this happening in a peach, if it were as an example. The cytoplasm is that outer fleshy part of the peach that you eat. Your DNA is locked within the nucleus. The vector vaccines are a little bit different in that the adenovirus vector, being an infection that people get, is just that you're being infected with a pretty benign adenovirus that doesn't cause illness and will degrade. It has a key to the nucleus. But what it's delivering a DNA message that leads to the formation of mRNA. The mRNA gets out into the cytoplasm, and at that point, it started looking pretty more or less like your mRNA vaccine after that, in terms of engaging the immune system. And then we now have newer kids on the block, so to speak. So we have the mRNA vaccines that we knew about, and then we have the viral vector vaccines. And what's new now is we have our nanoparticle viral like vaccine, the Medicargo vaccine, and then we know that there are other vaccines that are available, like whole virus vaccine that's not available here in Canada. And then, of course, the protein and peptide subunit vaccines. So the field is expanded in a very positive way. Let us look at 2 of these. One of these is the Novavax vaccine, which we said was a synthetic nanoparticle containing spike protein. And this basically summarizes the data from the clinical trial. And the two points, this was done in the UK. They had about 7,000 people in the active vaccine arm, and another 7,000 or so in the placebo arm. The one disappointing thing, and I alluded to disappointment earlier, is that when you look at the race or ethnic breakdown, there are only 26 Black folks in the Novavax arm, the active arm, and 26 in the placebo. And that's where the disappointment is. We got to do better than that. So that, I think, is certainly something that struck me when I looked at the representation of racialized folks in this particular clinical trial. I realize that there are many reasons for that, but I'm just saying it's a concern. When they looked at the overall vaccine efficacy, you can see the efficacy for different subgroups on this slide. And for the most part, you're looking at efficacy that are just short of 90% on average. One has to bear in mind when looking at vaccine efficacy, it's difficult to compare vaccines done at different times when different variants were circulating. But this sort of efficacy is pretty good. The Novavax trial, which is another area of caution that we need to watch, and a bit of a disappointment, and again, just being very frank, is that the clinical trial identified cases of myocarditis and or pericarditis after vaccine. This was rare. And they saw cases in the vaccine arm, but they also saw a case in the placebo arm. So the cause and effect relationship is not clear, but it's certainly something that we would need to watch very carefully moving forward. But in terms of full disclosure, it was seen, and it's certainly something that we have to monitor very carefully. Then the other vaccine that I think is exciting is the medical cargo vaccine. Both are exciting, new kids on the block, so to speak. And they looked at over just about 24,000 people, 18 years and above across 6 countries. I don't have information on the ethno-racial breakdown. We're looking at efficacy rates of between 75 and 88% against Delta and Gamma, respectively. So the Medicago is a plant-based vaccine that leads to the creation of a viral-like particle that essentially has the immune system seeing what looks like a virus, but essentially a little, particle containing spike protein without any nucleic acid material. So I think more work needs to be done on these in the post-marketing surveillance to see what the adverse events are going to be like once they become available. So what are the ingredients in these new vaccines? The first is just to recap in a minute or so what's in the old vaccines. It's hard to imagine that we're calling the mRNA vaccines and the viral vaccines old, but you know what I mean. And so this is a Pfizer vaccine. We said it's an mRNA, and I think of it like an mRNA with a lipid coating and salt and sugar. And I often use the example of a chocolate-coated raisin to just illustrate how it's made up. And the Moderna vaccine, the same basic structure. The AstraZeneca vaccine, the medicinal component, along with non-medicinal components are shown here. These are products that we are very much acquainted with in medical use. So there's really nothing here that's new that we are not using in medicine at the moment. And the Johnson & Johnson vaccine, the same thing. The Novavax vaccine medicinal component is shown here. It's basically a spike protein. The non-medicinal components, again, nothing that's new as far as the non-medicinal bit. The matrix M is interesting. It's a nano meter particle based extract from the soap bark tree. And this is the makeup of the adjuvant that allows for immune boosting. The Medicago vaccine is interesting. As I said, it's a viral-like particle delivering essentially spike protein. And then there are other ingredients as shown. And then adjuvants as shown that we've used in other vaccines. And the bit that I've highlighted is it sort of caught my eye simply because it says it may contain trace amounts of polyethylene glycol. That's fine, we can deal with that. Kanamycin, nobody gets that nowadays in clinical practice, but also carbenicillin, which is a penicillin derivative or penicillin family agent. So I'm still trying to get my head around this, and I've been in touch with my allergy colleagues to see how we would handle a case of somebody who said, I have anaphylaxis to penicillin. Can I get a Medicago vaccine? We don't have the answer to that yet, but I just want to highlight that as something that we're working on. If you go by the strict product monographs, they basically say that if you're allergic to an ingredient within the vaccine, then the vaccine is contraindicated or maybe relatively contraindicated. But these products, these trace amounts are not strictly speaking ingredients, but the manufacturer makes reference to the fact that trace amounts might be present. And as you've heard me say before, the manufacturers are required by law to declare everything, even tiny traces. And it's like, you buy certain products and they say may contain traces of peanut, right? So it's that same idea. So more information to follow on this. Now, let's move on to our fifth question, the issue of third doses, just watching the time. Do third doses provide greater overall benefit in terms of effectiveness? And this slide shows 2 versus 3 dose regimens of the mRNA vaccines in the United States among adults with and without weakened immune systems. This is across several hospitals in the United States, and this was a period pre-Omicron. And just to orientate you on this busy slide, I didn't want to change it. I was worried that I might make a typo on it. So first, where my cursor is, you can see patients without immunocompromising conditions. And then at the bottom where my cursor is, immunocompromising conditions. In blue represent 2 doses. And you can see for 2 dose, people with normal immune systems, the overall vaccine effectiveness, pretty more or less during Delta, 82%. If you have a weakened immune system, it fell down to 69%. With 3 doses, you can see the effectiveness went from 82% up to 97%, and 69 up to 88%. So there's clear benefit that the third dose was resulting in increased effectiveness during Delta among adults. During Omicron, the data also showed that there was benefit from a third dose. So it really does appear that there is benefit even during Omicron. Again, one is looking at hospitalization here, which hospitalization would be classified as moderate to severe illness. But you could still get COVID at the milder end, almost along the lines of what I said earlier. You got chicken pox with, if there's a breakthrough, but it's just mild with a couple of spots. Well, that's what it is the equivalent of what we're seeing here. Now, if you look at children, again, during the Delta period, teens, 12 to 17 years of age in the United States, is the data from the CDC. You can see a vaccine effectiveness of about 92 to 94%. So that's pretty good after 2 doses. Now, there are some reports, this one came out of New York, that suggest that the vaccine response wanes over time among teenagers. And they basically showed that with a 2-dose regimen, there was a drop in vaccine effectiveness. And this was really quite dramatic, as shown here, both in the 5 to 11 and the 12 to 17 age group. There's some controversy around this. The CDC looked at this more closely on this slide. Not one of those slides I didn't want to alter, but this CDC looked at different age groups, 5 to 11 with 2 doses, 12 to 15, 16 to 17, at a time when there was Delta and Omicron predominance, and basically showed for the 5 to 11, the effectiveness was 74%. For the slightly older age group, 73%. For the even slightly older than that, 94%. So you're looking at 73 to 94% effectiveness in the children 5 through to 17 years of age. But there's no question that immune responses wane over time. Here are 3 groups. The kids who are aged 12 to 15, 16 to 19, and adults who are greater than, equal to or greater than 20. The dotted lines represent the confidence intervals around this. And I think the key point is that if you follow where my cursor is at the bottom, you can see over time, so by the time you get to about 6 months or so out, you can see that vaccine effectiveness against symptomatic infection has dropped into less than 7%, 70%. So this speaks then to the need to keep these lines up. And that's where the 3rd dose boosters come in. And so if you look as well at the youngest age group, you can see the rate of decline, the middle age group, rate of decline, and then the older age group, you can see the decline. They're heading in the same direction, but they decline different rates. Important point though is several months out, there's a decline, and that's where the boosters come in. Now, let's move then to the question of, well, if we want to vaccinate kids, teens, and young adults with a 3rd dose because they're losing protection over time, is this safe? Are these 3rd doses safe? And to put things in perspective, where this all comes from, why we're really so focused on this, is a recognition of this myocarditis, pericarditis, fly in the ointment, so to speak. And this is an entity that on this slide, it mirrors what we see in terms of the age distribution. It mirrors what we see with myocarditis, pericarditis outside of the setting of COVID. And in that regard, when you go from teen to the younger age groups, the signal falls. So the age group 5 to 11 is a relatively quiet zone as it relates to the risk of myocarditis. But it heats up in the teenage years and young adults. And so if you want to give a 3rd dose during that time, the first question is, are you going to get more myocarditis? And so if you look at the myocarditis data coming out of the United States, you can imagine what I just showed you with the previous slide. As you get older, through the teenage years, peaks, they saw that it was falling off. And as you get to, above 30, you can see it's tailing off. So the period of, adolescence, young adulthood is a period that we watch very carefully as it relates to the risk of myocarditis, and hence 3rd doses, we want to be very careful in that regard. So what have we seen? So based on preliminary post-marketing data, there've been no safety concerns associated with these third booster doses beyond those that were seen with the primary 2-dose series, if you call that a primary series. So the 2 doses, the boosters didn't seem to do anything worse. It appears that certainly in terms of adverse events, the mRNA boosters, the rates of adverse events would be comparable with or lower than that was seen after 2 doses. So if you didn't get in trouble after 2 doses, overall, it's not likely that you would get into trouble with a 3rd dose. Having said that, there's a report in the UK that I'll come to in the next slide. But for the most part, when we did experience issues with 3rd doses of pericarditis, myocarditis, just as before, with 1 or 2 doses, the cases tend to be very mild and patients recover without consequences. But in the United States and Israel, the rate of myocarditis after the 3rd dose seems to be less than the 2nd dose. So if you didn't get it by dose 2, you're not going to get it up by the 3rd dose, but more than dose 1. So it's sitting somewhere between dose 1 and dose 2 in terms of frequency. The exception is, and we're watching this very carefully, is relates to data from the UK that suggests that perhaps the 3rd dose might be associated with rates that are higher than dose 2. So this is yet to be confirmed, but it's certainly something that we're watching very carefully. Now, what about the timing of the 3rd dose? I won't say much about this except to highlight that the information is available on the Public Health Ontario website. In the interest of time, I want to just highlight 2 or 3 points. Let me go to those points. Number 1 is that for individuals 12 to just less than 30, what is recommended is the Pfizer vaccine because of a lower rate of pericarditis, myocarditis with the Pfizer compared with Moderna. Pfizer 30, lower compared to Moderna 100. So that's take-home point number 1. Take-home point number 2 is that for the individuals who are older and residents of long-term care facilities, either Moderna at 100, Pfizer at 30 might be used. And take-home point number 3 is that there is some suggestion that the Moderna might give you a slightly more pronounced immune response. And so for individuals who are immunocompromised, who are 30 years and older, perhaps they should be getting Moderna. And the final take-home point is that for everyone else that require boosters, then they can get Pfizer at 30 or Moderna at 50, so half the regular dose of Moderna. So all of this is available on the Public Health Ontario website. It's good as educators, physicians, nurses, people are providing information to others on these vaccines. So just read it a couple of times to get your head around it. So in summary, then I've shown you data related to different things, where we are now with these vaccines. I think if I were to say one key take-home point is we're still in a pandemic, and it, as I've shown you before, with waning immunity, it's important to get the 3rd doses in wherever they're recommended. And what about 4th doses? Information is coming out on this. showing you here data from the United States. CDC recommends, the four Pfizer Moderna doses, folks 50 and over. So this is being fine-tuned. This is the media stuff, so it's all over the media. Canadian media, 4 doses coming to Ontarians. When I did this slide was yesterday, and today you've gotten the announcement. And so with that, I will stop, and I'm happy to take any questions. Thank you.
Thank you very much, Upton. That was very clear and very concise. So we have one question, very interesting question from Katrina. You expressed initially your disappointment that the Novavax trial didn't enroll sufficient people of Black descent. Now, what Katrina is trying to allude to in her question is why this remains a cause for concern, knowing that the racial differences are mainly social constructs rather than real true evidence of genetic diversity. And what she's trying to raise is that aren't we over stressing that point and maybe sometimes being too skewed on one side of the equation?
So that's a really great question. I'll make a few points in that regard. When we have interacted with various individuals from different communities, there's a certain comfort with knowing that the vaccine that is being given to them was studied in individuals like them. There's a certain comfort associated with that. That said, we recognize that the way that people respond to vaccines in terms of the immune response, there have been a number of assumptions that have been made that have not yet been established. And so one doesn't want to be provocative, but the idea that the types of responses in an East Asian and a Caucasian will be the same as someone of African ancestry, despite what we hear in the media, it's not there yet. It's actually one of the things that we started studying 2 years ago, and there's currently a major international project that is looking at this from different angles. So the verdict is still not there on that in that regard. But that said, while that research is still being done, as I said before, there's a certain comfort with knowing that the pill that you're getting, the vaccine that you're getting, was studied in a population that looks like you.
Thank you. So back to the issue of need for boosters. So you've made a strong case that the third dose is efficacious and necessary. Now we are in the era of 4th dose, which seems to be limited to the older age group who are more likely to have waning immune response and more likely to have severe disease. Is there going to be a 5th, a 6th? Where is this heading?
That's a really great question. When I was preparing my presentation, I paused for a moment and I said, how many doses of influenza vaccine I've gotten in my lifetime? And I concluded that I'd gotten about 30. Because, I've gotten it every year since the 90s, right? I don't know that's where we would go with Pfizer or Moderna vaccines or COVID vaccines, period. But it's important to recognize that for certain types of individuals, because of their high risk profile, such as being a healthcare worker like myself, or working in a long-term care facility, or being an elderly person, it might well be that some of those individuals do require fifth doses, and who knows, maybe in 2 years from now they might need another dose. So I think it's important for us not to close the door on the fact that in the future, hopefully we don't get there, but in the future, it might well be that certain groups of individuals, by virtue of risk, might require additional doses. But I certainly do not expect that the general population would be getting, multiple doses moving forward. But just conceptually, it is possible that there will be some additional doses. In fact, what I can say right now is that within one of the hats I wear is as an infectious disease person who takes care of organ transplant patients as the interim director of the transplant center. I can tell you that we're going to be talking about tomorrow morning at 7 a.m. Whether or not there are some of our transplant patients who might actually qualify for fifth doses because because of the nature of how compromised they are.
Yeah, in that regard, I'll just take 2 comments and questions. In that regard, Ato is suggesting that perhaps the term booster is misleading and we should probably move away from there and let people know that you need 3 doses.
Yeah, I absolutely do agree with my friend and colleague Otto in that to frame this as third doses as opposed to boosters, and I was one who advocated for us doing that, but it seemed like with the knowledge translation, the community was so locked into the idea that third doses were boosters that people are now using it. But absolutely 100% agree that we should be talking about a third dose for series completion, and then beyond that you could talk about boosting.
Yeah, and Dominic is making the point that I asked, that given that the effectiveness drops below 70% after about 120 days, where is the end point? Is it the 4th? Is it the 5th? Is it the 6th? So the same idea that
right. I think it's going to be risk-based. I really do. I think that it's going to be risk-based. It's I really don't expect that the average person in the community will be getting multiple doses the way we do influenza.
Right. Well, on that note, we will shift to our second speaker. We'll come back if there are any questions at the end, but let's get in. So we have another chief, this time Chief of Infectious Diseases at the Children's Hospital, London Health Sciences. Dr. Michelle Barton-Forbes is a well-established infectious disease expert, has a special COVID-19 virtual clinic and special vaccine clinic for children with regards to decision-making. She's going to really focus on treatment and take us through what is new and what is hot. Michelle, over to you. If you could change to presentation mode. Yeah. Perfect. You're muted.
Hello, everybody. I am following on Dr. Allen's excellent talk. and taking you to the other side of COVID management. Well, he dealt with prevention, and now I'm going to, in this section, deal with treatment. And I want to say that a lot of advances have been made over the 2 years as it relates to understanding COVID. Dr. Allen told you about efficacious vaccines, but we have learned quite a bit about COVID-19 over the 2 years. In particular, we have a better understanding of the spectrum of disease and the potential complications. We have delineated the risk factors, and we have an understanding of the pathophysiology that has placed us in a good stead to create a path for major therapeutics. So in this talk, I'd like to overview a little about the spectrum of COVID-19 disease, in particular that requires treatment, and then look at the spectrum of severity, treatment based on pathophysiology, review quickly the pathophysiology, and then risk determination and drug therapy by class. So COVID-19 has a spectrum of diseases, and we focus, and this talk is going to be focused on acute COVID-19, but there are also later manifestations of COVID-19 as it relates in children to a multi-inflammatory syndrome, multi-system inflammatory syndrome in children. And then we also are aware of the later manifestations of COVID as it relates to long COVID. In terms of acute COVID and MISC, those are the syndromes that are associated with significant morbidity and potential mortality. Well, definitely mortality in adults, thankfully not as much in children. So in acute COVID, we know that hospitalization rates, at least pre-Omicron, in children is really quite low. And in adults, the rate of hospitalization is a measure of the vaccination rate in the adult as well as the age group. So older adults over 70 are probably even more likely to be admitted if they have infection. We know that the disease can be severe with a significant component being admitted in ICU, in particular in adults. In children, only 20 to 25% of admitted cases end up in ICU. When we look at MISC, on the other hand, we know that this can occur after asymptomatic or symptomatic infection in children, and about 3% of children will go on to develop this serious illness, serious enough because it has to be, the children require admission. Fortunately, they most do well, but a significant chunk of them will end up in ICU. And the rates vary. In Canada, our rate is 31%, but in the States, it's up to 75% that has been quoted. So these two syndromes are present with significant morbidity and demand treatment. And thankfully, over the 2 years, we've come to understand the severity of acute COVID, and we now know which people are more likely to progress to severe disease. So our approach to treatment can be stratified by risk. And then, of course, also stratified by severity. So all patients who are admitted to hospital requiring oxygen therapy require COVID intervention, therapeutic intervention. Whereas with the high-risk patients, some of the high-risk patients who are not admitted actually benefit from treatment. With MISC, that affects children, all children with that diagnosis require treatment. As it relates to long COVID, that is still a blur. We still don't have a good understanding of what's going on with that syndrome, and we know we have no treatment available, and it's supportive. So our talk now will focus on acute COVID going forward. As it relates to acute COVID, we spoke about the importance of understanding the spectrum of severity. And so you get infected with the virus, and you are incubating that virus and may never show features of symptoms of infection. That's the asymptomatic group. However, some people move on to become mildly symptomatic. And if you're mildly symptomatic, you stay home and you don't require any hospitalization or therapy unless you're a high risk. And then, of course, by the time you require oxygen, you need to be in hospital, and that's the moderate to critical group. And those patients obviously require treatment. So to understand the treatment, you need to understand what exactly is happening in each phase. So COVID-19, the infection is broken down into 3 stages. Stage 1, which is the early stage, is when the virus is actually actively replicating. And in that phase, you go from your incubation to your early symptomatic period. Some people remain asymptomatic. The virus replicates, it peaks, and then wanes off in the second stage. By the time you start waning in terms of viral levels, this is when the host response chips in, the blue line. So the blue curve is your host response, the inflammatory response, and that comes in stage 2, and in some individuals can get quite aggressive, what we call a cytokine storm or hyperinflammation, and that occurs in stage 2 and peaks in that stage. So you see a timeline at the bottom that the first stage is usually in the first week, the second stage is in the second week, and beyond that, you're into the third stage. Just to give you a better understanding of the pathophysiology, let's just quickly go through what happens. When you inhale SARS-CoV-2 virus, it gets to your nasal mucosal cells, and an entry takes place there, and you can get a localized inflammatory response, subdued. And for most people, they clear the virus on their own without treatment, 80%, and it's cleared within 14 days. In a subset of patients, about 20%, the activity is not limited to the upper airway, but it also involves the lower airway cells. And there is replication, viral replication going on in these lower airway cells. And as a result of this viral replication, the host response gets turned on, and you get all the inflammatory proteins. This box here refers to the inflammatory proteins, which we call cytokines, and other chemokines, etc., being released. At the same time, the virus is also replicating within the host cells and causing, destruction. And as that happens, you can see that there are two methods or 2 pathways to lung injury. One pathway is by the inflammatory proteins that your body's secreting, the cytokines, and these actually are they drive the inflammation to the point that you're getting other cells coming in, things like neutrophils and other types of lymphocytes that help to fight infection, CD4, CD8, in particular CD8, which is quite cytotoxic. It results in damage because as these cells sequester or pool in the lungs, you end up with lung injury. At the same time, while that is going on concurrently, your host response, there is a viral replication that is also going on concurrently, and the viral replication on its own is creating a cycle of damage within the cells, and you end up then with damaged lungs, and you're presenting respiratory failure. Present with acute respiratory distress syndrome, which progresses into respiratory failure. So there are lots of host cell inflammation, host cell activity creating inflammation, and that measures itself. If you were able to measure the proteins, you would see that these would be high. But as a result of the white cells, the lymphocytes, creating the killing of the cells, you're using up your lymphocytes, so your lymphocyte count is also low. Okay, so that's in a nutshell what's happening pathophysiologically in the lungs, and then of course it can spill over to other organs. This is just a quick, even though I'm not dealing with long COVID, but long COVID, it's still not fully understood, but it's felt that there is ongoing viral reservoirs or viral activity that is creating, similar to the viral activity that we saw in the previous slide, that viral activity can actually create tissue damage at the sites where the virus has found a reservoir. So it might find reservoirs in the brain, it might find reservoirs in other organ systems. And in those organ systems, the postulate is that the tissue becomes damaged. And when your tissue becomes damaged, you then can have an autoimmune response where your body fights against itself, and you end up with this autoimmunity cascade, and the symptoms depend on which system is affected. All right, let's get back to acute COVID. So acute COVID, we spoke about the viral replication that's happening in the early stage, and then the inflammation in the later stage. Now, relating, how does that relate to the therapeutics? You see in orange, antiviral, and part of it is hatched with basically shaded with vertical lines, and that shaded area really looks at optional treatment. In other words, treatment within a subgroup, only high-risk patients. So if you're a healthy host, you don't require antiviral therapy until you get into hospital and are required oxygen. The patients who have altered immune systems or have multiple risk factors for severe disease, the thought is, if you can shut down the viral replication in this early phase, since the viral replication is what's driving the secondary host response, then you may win the game by shutting this down in the patients who are at risk for severe disease, in other words, the hyperinflammation, dealing with this early by giving them antivirals, or below in green is the monoclonal antibodies. So basically you can address viral activity either by giving an antiviral agent that shuts down the replication of the virus, or you can actually give an antibody that basically neutralizes the spike protein. It zaps the spike protein, it binds to the spike protein and prevents the activity. So you are then basically halting the effect of the virus to try to reduce this hyperinflammation. Once you get into the second to third phase, you need anti-inflammation, because that blue curve is actually on the rise, and this is where treatment is geared at anti-inflammation. Okay, so this is showing you again, Dr. Allen spoke about prevention using vaccines in the green area, and then we have treatment in the red and pink area. The pink area would refer to patients who are not admitted, and the only patients who are not admitted with mild infection who require treatment would be patients who have some underlying risk for severe disease or are immunocompromised. And we just spoke about that in the previous slide. Whereas healthy persons like myself and yourself, if you get sick with COVID and end up being admitted, you are admitted at the point that you require oxygen, and so you need treatment. There is host inflammation going on. All right, so question is, we speak about this high-risk group. Who is considered high risk. So to determine the risk category, we use different key factors to look at. One is the patient vaccinated. In particular, for that's very important for adults. It's important for children too, but we have a subset of children who are not vaccinated because they're not eligible. Anyway, we know, as Dr. Allen showed you in the slides, that vaccination makes a difference. You end up with high levels of antibodies early after vaccination, or if you've had multiple doses boosted, with your third dose and stuff, you end up with good antibody levels that can now neutralize the spike protein on the virus. So if you're not vaccinated, that's an edge against you. In addition, you may have a subset of patients who are vaccinated, but you can predict that they will have poor responses. And I'm talking about patients who've been transplanted or who are on immunosuppressive agents. Their capacity to respond may be suboptimal. And in those patients, you might need to think about, even if they're vaccinated, they may not mount an appropriate response. Or do they have an underlying condition that even if they were not vaccinated, I can't predict that they will have a good natural response? So those are patients who have primary immunodeficiencies, patients who are on steroids, high dose steroids and other drugs. That's that category. Then the next question you ask is, are they at risk? Do they have at-risk comorbidities? There are certain comorbidities that I'll show you in the next slide, that if you have more than one of those, in particular, some people say 3 or more than 2, then you may have a higher risk of progressing rapidly from mild to moderate to severe to critical. The next group is, are you pregnant? Because the pregnant women have been shown, in particular if they're not vaccinated, to have a higher risk of progression. And lastly, are you at the extremes of age? In particular, adults who are greater than 70 years of age, even if they're vaccinated, they are considered quite high risk. So these are some of the immune-related issues that may impact ability to mount a response to the vaccine or a natural response. I spoke about some of these already. Several studies have been done that have shown that these are factors that influence likelihood to progress to severe disease in adults. Obesity is a big one, but there are other things listed here that you see. In particular, sickle cell disease, since I'm speaking to an audience that maybe caring for Black patients, you need to be aware of that group as well. For children, the comorbidities that have been shown in Canadian-based studies as well as US studies, these are some of them. Some of them overlap and some don't, but yeah, things like poorly controlled asthma has also been shown. Obviously, just one factor is not sufficient to push you over into treatment. It's multiple factors that the doctors take into consideration. Okay, so a normal risk person would be not pregnant, not over 70, have no comorbidities that are associated and are not known to be immunocompromised, and ideally vaccinated. So that I was just giving you an example there. For example, if you're pregnant and unvaccinated, you would be considered high risk. All right, so what are the options for high-risk persons? So the options really go back to the slide I showed you with the what's happening in the early phase. What's happening in the early phase is viral activity. So you want something to shut the viral activity down or to prevent the virus from moving on to bind to the cells. So you are looking at antiviral agents or neutralizing antibodies. And in the first wave of Omicron, we were using monoclonal antibodies like sotrovimab quite a bit, and it was working really good. But in this second wave, the BA.2 subvariant is now not active. The neutralizing antibody is no longer active to the BA.2 subvariant. There is a promising new monoclonal antibody that retains activity to the BA.2 subvariant, but it is not yet approved in Canada, and in the States, it's approved only for investigational use. But it's promising, and if this wave really gets to be high level, we'll have to, we look forward to seeing whether this becomes approved, because then our immunocompromised patients may benefit from this monoclonal antibody. Then of course, everybody knows about the antiviral agents. There are intravenous antiviral agents, in particular remdesivir, and then there are oral antiviral agents, molnupiravir, and for shorter term, I'll say Paxlovid. So these agents are predominantly for the oral agents are predominantly for adults, because they're not really approved for children, but may be used under certain circumstances in older children, of course, with an infectious disease specialist guiding. As it relates to remdesivir is approved for children and adults, and it's an intravenous. So it usually is administered within hospital for children, although I know that adults have come in daily for that treatment. So this is what the flow chart for treatment would look like. You would have to decide if does the patient have underlying risk factors for severe disease, or are they free from risk factors? If they are free from risk factors, then we don't do anything in a green box for them. If they are mild, it's just supportive treatment. They're at home, they're drinking fluids, etc. If they are moderate, once you are moderate to severe or critical, it suggests that you require oxygen. There's some amount of low oxygen hypoxia, and so you have to be admitted. So if you're low risk and you're admitted and moderate, you would just get steroids for the most part. So most times you don't need antivirals, but it's there as a backup if on steroids you're still getting worse. On the other hand, if you have risk factors and you are mild, then if you have significant risk factors or are immunocompromised, then these patients may benefit, some of them may benefit from some sort of intervention, early intervention that's targeted at the virus or the spike protein. Right now, as it relates to the antibodies, we currently have none available for this BA.2 outbreak. However, there are antiviral agents that may be considered on a case-by-case scenario. And then, of course, if your high-risk patient is admitted and requiring oxygen, those patients usually require some antiviral agents as well. And of course, because COVID may be associated with an underlying pneumonia, some of these children or adults may need antibiotics. By the time you get to severe, there's no real, everybody's in one barrel. Basically, you're on high flow oxygen, or you may need some support in ICU. These patients require steroids and remdesivir, steroids and some antiviral agent, plus or minus some stronger immune modulation using biologics. We'll talk about that on the next slide. And definitely by that last stage, you're looking at those interventions as well. You might need to put the patient on some sort of bypass to rest the lungs. So we've spoken about monoclonal antibodies. Those are the neutralizing antibodies. We've spoken about how antiviral agents act, and then the immunomodulatory agents basically are dealing with the host inflammation, the hyperinflammation. So these first-line immunomodulation is with steroids, and then second line is with biologics. So this table just kind of gives you an idea that we've gone through a whole set of generations of monoclonal antibodies that initially worked for the Delta variant, and even some of them worked for the BA.1 variant, but no, none of these except for the one at the bottom, bebtelovimab, which is really not approved yet for use, is the only one that retains activity against the BA.2. And this paper just shows the whole impact of variant, subvariant epidemiology on therapeutics, highlighting that we've lost quite a lot of our monoclonal antibodies as it relates to this new emerging subvariant. Then the antiviral agents, remdesivir was the one that was first approved for use, and it actually was around and being used in the Ebola outbreak, and also has been was developed for its activity against hepatitis C viruses, but was subsequently approved in this pandemic when studies show that it actually significantly reduced, significantly improved the recovery time, 10 days versus 15 days in patients who received it, but mainly in those who received it who were moderate to severe, not critical. And then we have the two newcomers on the block, the oral antiviral agents, Paxlovid and Molnupiravir. These are available for adults who are at high risk of progression. However, notably, Molnupiravir cannot be used in pregnant women or children. In terms of the biologics, we're looking at things that basically address the cytokine activity, inhibit cytokine activity, IL-6 inhibitors. And then, of course, there are JAK1 and 2 and JAK1 and 3 inhibitors that have been used. This basically just shows that there is the dexamethasone was the greatest breakthrough that we had for the pandemic as it relates to therapeutics, because it was the first drug that was shown to save lives. And you can see that it definitely had a mortality benefit high. Here, you can see that in 8 randomized trials. So definitely. In terms of the IL-6 inhibitors, these are the ones, the main one that we use is tocilizumab. And these agents are great, but they're not without potential toxicity or complications as it relates to immune suppression. But weighing pros and cons, obviously, if a patient is sick enough, they will need it, and we use it. And then, of course, the JAK inhibitors. These are basically anti-inflammatory and have a potential antiviral activity. And we're talking about really baricitinib, which is the only one that is available for use in children. These other, the tofacitinib is available for adults as well. They have their own adverse effects that you need to be aware of. So in summary, I'll take you back to our first figure. Really, the aim of management of COVID is really to prevent. That's your aim. And this is where Dr. Allen spoke to vaccines. This is what you want to do. You want to reduce the likelihood of severe disease. You want to be able to protect the immunocompromised patients and the patients with high risk by intervening early. So you consider early treatment in the mild stage, and you want to treat all patients who are admitted with moderate to critical disease, giving them dexamethasone plus or minus antivirals. And of course, if they are progressing rapidly to hyperinflammation, you are going to add your biologics. We did not mention this, but this is a part of the management of a severely ill patient with COVID, addresses prevention of clots, and that needs to be considered as well. So where are we going? We still need to come up with more therapeutics. This pandemic is not over. The subvariants that are emerging are outsmarting us as it relates to monoclonal antibodies. And so we need to remain ahead of the game. There's ongoing research that's going on. Several agents are being studied. And we look forward to the discovery of efficacious agents to help us in the fight or in the treatment. But really, back to the take-home message, if we can prevent, that's what we should be doing. Thank you.
Thank you very much. That was a tour de force on the progress we've made in being better able to manage patients. So while we're waiting for questions in the Q&A, please post your questions. Michelle, is the progress being made in therapeutics providing false hope for people who are slacking in the preventative approach?
That's a really good question. And I really should have said something about that, because I remember when the oral antivirals were released, a whole set of anti-vaxxers, parents started calling and saying they don't need to give the vaccines because they will be able to get the antiviral agents. And I think we need to understand that the antiviral agents are not without side effects, one. Two, Paxlovid, for example, has numerous drug interactions. You need to be able to diagnose that infection early enough, because you only have a 5-day window, early enough to be able to intervene. And it is not an option at all for the healthy individual. So if you don't have underlying risk factors, you're not eligible. So it should never be seen that the current therapeutics that are available should never be seen as an option or an opt-out of vaccines, because that's just not on. It's not available for the healthy people.
Thank you. Upton.
Yeah, and I agree 100% with Michelle. I guess one other point that I'd make is that it's really important to remember that the drugs like Paxlovid act after you've been infected, and it's possible, and perhaps I think quite likely, that individuals who get infected, even if they get treated with Paxlovid, a subset of those might still go on to develop long COVID. So there's a difference between the consequences of infection versus the consequences of disease. And it might, disease meaning infection plus symptoms. And so it is possible that you might well get infected, you get treated, and you still have long COVID. So it's really important to just what our grandmother said, really trying to, an ounce of prevention is much better than,
Yeah.
all the cures you can try.
Michelle, I saw your reagent curve seems to be active against the BA2. Is that established?
Sorry, I didn't hear what you said. Sorry.
So the reagent curve combination of antibody therapy, is it active against BA2?
No.
Or I thought your slide suggested that.
No.
Right.
Let me show you the slide again.
So the one that you had the
here.
yes. So you have it. Yeah, so you have the BA2 ticked. And you said maybe available in Canada. So
Oh no, that's a mistake. Sorry.
so that,
Yeah, sorry,
so
that's a mistake.
You see,
Only.
I was paying very close attention.
Oh, you were for sure.
Right. Okay, we have two other questions on the. So Dominic is asking, a challenge with initiating therapeutics in high-risk patients is the timing of initiation. With delayed turnaround time of COVID test results and accessing the drugs, these are posing as barriers. Any comment on that?
That's definitely a challenge. And so one, I think there needs to be education of so what we have done, like from a pediatric standpoint, is to educate our most responsible physicians, like physicians taking care of transplant patients, physicians taking care of patients who have some sort of, like the immunologists who are taking care of primary immunodeficiency, that sort of thing. We say to them, the more you need to educate your families, and as soon as they get sick, they need to be able to come directly to, so they come to Emerge and get tested. And so we have a turn, because we don't respond just to a rapid test at home. We want to get a proven PCR test, so they have to come to the hospital. So I think one, we need to educate the high-risk population about the importance of early testing. And two, we need to make sure that our test centers are sensitive and aware that this group of patients require testing and they're not sent home. And then there needs to be some sort of pathway, easily accessible pathway within system that is set up for these patients who are high risk and are positive. So in other words, of course, everything is subject to drug availability, but still there needs to be a mechanism in place that ensures that they get the drug that they need.
Right.
Michelle, can I just comment? I agree 100% with you and with Dominic. I think we need to do some work on that. I mean, because can you think of a scenario where you have COVID, your kids have COVID, and then your grandmother, who is high risk, develops COVID. I think she should get just started on treatment. We don't need to test her. So I think we need to do some work with respect to the algorithm that Dominic's alluding to. So I think we need to tidy that up. Not everyone, I think. I mean, we've done this for influenza, right? So I think we need to do something like that.
Yeah,
I think in that situation where you know that it's circulating, but you just have a transplant patient who is just calling saying that they have symptoms of COVID and nobody has tested positive in the home, you need that patient to come in.
Right. So we have time for one more. There was one left over from Upton's talk from Sheila, who is asking about cellular immunity. It doesn't seem like we talk a lot about it. Is that any factor with the messenger RNA vaccines?
Yeah, it is being studied now. And in fact, we're doing a project on that. One of the, where we are now is that it appears that there's there are some patients who we believe might have low levels of antibody, but they still have some degree of cell-mediated protection. So I think that's really good. It might also be, and there's some data from Daniel Kaufman from Montreal that would suggest that perhaps if you had COVID before and you got one dose of the vaccine, you might have some pretty decent level of cell-mediated protection that might be comparable to 2 doses of the vaccine. So again, these are preliminary data, but it's highlighting the important role of cell-mediated immunity. So definitely is being studied. It's just a very difficult thing to incorporate in most of the research that's been done because it is so, labor intensive. As Michelle knows from some of the collaboration that we're doing, it's so labor intensive to do the cell-mediated immune testing.
Yeah, doesn't lend itself to clinical practice.
Yeah.
So finally, one more question. I think are healthcare workers being prioritized for 4th dose? Regardless of age.
Yeah, the 4th dose issue is still being rolled out. And so my feeling is that it's likely that healthcare workers will be in that category. But if you ask me, well, gee, is it 30-year-old nurse or doctor the same as the 65-year-old, so there's some more work that needs to be done in trying to sort it. So what I must say though, is that I would really strongly urge everyone who's not had their 3rd doses to go and get that before worrying about 4th doses. I think,
right. Well, on that note, I think we've had a good time with the 2 chiefs who are the best in the business and have done real justice to the topics. And thanks for your attendance and your participation. Please provide your feedback on the session because they help us with other sessions that we are planning in the future. So thanks for joining us for the 13th in the series. We are promoting vaccine education, and today we got treatment education as well. Have a good night, and thanks for joining us.
Thank you.
Bye-bye.
Bye-bye.